Thank you so much for that, and thank you so much for the kind introduction. I'm very privileged to be here tonight at the launch of the SofaCON 2021, and I'd just like to thank everybody who's taken time out of their evening to join us tonight to listen to me talk about this topic, which I think would be relevant to a lot of us in our clinical practice and is something that is up and coming, and I think worthy of us spending some time to really explore it together. And thank you so much to the SofaCON team for their amazing efforts to pull together another SofaCON 2021 after their wonderful efforts last year. It's really fantastic to see such commitment to the ongoing learning and education of clinicians and being able to provide those resources for free for clinicians to take advantage of them. So without much ado, I'm going to get stuck into it. I'll just give you a brief introduction of who I am. I am a Brisbane-based specialist periodontist. I did my undergraduate training at the University of Otago in New Zealand, which is that beautiful building up the corner here. And I did my undergraduate and my postgraduate training at the University of Sydney under Professor Axel Spar's supervision. That's that beautiful building down the bottom there. And currently I am a fellow of the Royal Australasian College of Dental Surgeons and a member of this college's specialist stream in periodontics, as well as acting vice president for the Queensland branches of the Australian Society of Periodontics and the Australasian Osseointegration Society. So let's get stuck into it. We're talking tonight about failure. The word failure is a really significant word. It's a word that I personally don't like to hear. I'm pretty sure most people don't want to hear the word failure. And especially when it comes to your own patient management or your clinical protocols and your clinical practice. It's a word that a lot of us try to avoid or at least stay clear off of it. And before I get stuck into all the clinical things and showing cases and whatnot, I just want to spend a little bit of time considering a few points. It's very important to think about it. If I don't want to fail, I'm pretty positive most clinicians out there, or probably all clinicians, no one wants to go out there and complete a procedure and have it fail. It's pretty much against our nature as healthcare professionals to want to complete or execute a treatment that we don't stand behind, or we don't guarantee, or we don't support what we're doing with it. And it also stems from the name. I mean, we're called healthcare providers. It's inherently in our name that we actually care about the health of patients. And no one wants to, go completing a procedure and then have that procedure break down or have problems or dramas. And that's primarily the reason why people don't want to fail in whatever they're doing. But on top of that, there's so many negative ramifications on what can happen if an implant does fail. And these can be various, from an economical standpoint, a lot of chair time, patient frustration coming in, having to have things redone or rehashed. Obviously, the well-being of the clinician themselves. Nobody wants to go on a Friday evening and spend their entire weekend worrying and pondering, is my implant doing okay? What am I going to do about this situation? And for the unfortunate few who may have patients so dissatisfied that they seek legal action, nobody wants to go down those pathways. So it's really important to think about this. If no one wants to fail, from that you can derive or deduce that if somebody's trying to guarantee success, generally they tend to use whatever is considered in their own perception as best practice. So whenever I see a case that walks into my office, and unfortunately I do see a fair few, where an implant has failed, I often think that this failure has happened despite the clinician's perceived best practice. As in, this clinician wasn't out there to get that patient. They were trying to actually do the absolute opposite of that. They were trying to go out there and help that patient out. And despite that, things just didn't line up. And unfortunately, they ended up experiencing a failure of that implant. And if we put that, perspective right front and center of us whenever we're dealing with any failure, if you take a good look at it and think, this clinician was genuinely trying to help that patient out, and unfortunately things haven't worked out, our response should generally be targeted in that, first of all, we should think about that patient. Obviously, they've had the misfortune of the failure happen to them, and our approach should be around that patient, trying to support them, trying to make good of whatever situation that they're currently finding themselves in. And also, it should be a non-inflammatory response towards whatever other clinicians have completed. So if you know that this person was trying to do their best, obviously they may have been misguided, or protocols may have changed since back then, or whatever it may be. It's always good to be able to support that and say to the patient, look, I'm pretty sure they tried their best, but things unfortunately just didn't work out the way it is. And if anything, use this as a leading opportunity or a learning opportunity for us to be able to take a good hard look at ourselves and what we are doing in our own practice and say, well, if this clinician has done all that and they've tried their absolute best and things haven't worked out, maybe I should really take a look and see if I'm doing the same things. Because generally, what we want to do is to build ourselves onwards and upwards. We want to keep furthering our clinical skills, and we want to always try to strive to do better for our patients. So this is the perspective that I want you to go into this talk with. People try to do their best, but sometimes things just happen. And that's the first thing that I want to say. Failures are part of life. Failures are part of clinical practice. I'm pretty sure if we get, Olbrexon or, Bronnemark or any of these massive name, like, superstars of implantology, and we put them in this room, I'm pretty positive that they would have had some failures. And because of these failures, they've learned, they've been able to build themselves up, and they have basically changed the entire face of implantology from now and forever. So when I show the cases that I am going to show, obviously these cases are cases that I've seen. Fortunately, none of them I actually completed. These are external failures, but I'm not showing them for any purpose but that these were quite key learning cases for me. And these were cases which I have learned from and I would want to share with you to learn from. It is not to scrutinize other people's work, okay? All right, now that disclaimer is out the road, let's get stuck into the actual nitty-gritty of the talk. So we want to talk about failures. We have to be able to define what failure is. We have to understand what success is, survival, failure, and we have to know how often these things happen. Is it an isolated incident? Is it a frequent happening? How often does it occur? And why? Why would the failure occur? What type of situations can occur that would drive a failure? How do we classify failures? More importantly than failures as well is complications, because a failure is pretty much an end to the clinical treatment. A complication might be a running issue that's going on a day-to-day basis. And then I'll share with you a few cases that I've seen in my own clinical practice, and I will talk about how we have come around to manage them and what we've done, or lessons that have been learned, or I might not have been able to do anything to assist that patient, but what things we can learn from them. And from there, if we know what not to do, we can start using this as a tool for us to learn what to do on a day-to-day basis to try to minimize, reduce, or avoid these failures. And then we'll sum it all up at the end, okay? So, definitions. Carl Misch and co-workers in 2008, they came together and they had the International Congress of Oral Implantologists. And it was a consensus conference in Pisa in Italy. And they sat down and they came up with some information to us about what defines all of these things. Now, I'm going to start off with talking about success, because that's basically the target that we're aiming for. We want to be successful. And they have decided or defined this, and this is actually taken out of the paper by Misch and co-workers, and it says it's basically ideal clinical conditions. Now, that might not be super helpful to any of us. Okay, it looks good. Is that what it means? Not really. They have put a couple of little things in there for us to have a look. So they've said at least 12 months. So this has to be a functioning implant. It can't just be perfect sitting there, pretty in the bone, and not being loaded or restored or actually being utilized for any purpose. And you can actually define whether that success is an early success, as in within the first 1 to 3 years, or if it's an intermediate success, as in 3 to 7 years, or if it's a more than 7 years, which is considered a long-term success. And this is mainly talking about the fixture, not including the associated prosthetic that is actually sitting on top of that fixture. And I take this quote out of a paper that I read, and it says, the success criterion most commonly reported in clinical reports is the survival rate. Now, this becomes a little bit interesting. Success and survival are not the same things. Success means ideal clinical conditions. Survival means something completely different. It means it's there inside the mouth. Now, something being inside the mouth does not necessarily mean it's successful. It's just there. And basically, when we actually take a close look at what historically used to be considered successful, this is one of the very earliest success criteria, which was duly looked at as success and survival altogether. And Ulbrichtson had defined it as having no mobility, no persistent or signs or symptoms. So like as if you don't have neuropathy or you don't have a damage to the inferior alveolar nerve canal, that there's no periapical radiolucency or peri-implant radiolucency 360 around the implant. And this is an interesting one, less than 0.2 millimeters of annual bone loss. Now this is cumulative. So in 5 years' time, you can have an extra millimeter of bone loss. In 10 years' time, you can have an extra 2 millimeters of bone loss. In and so on, like in 15 years' time, then you can have 3 millimeters of bone loss. So that becomes an interesting concept. And that basically you will have within that first year a bit of normal remodeling or physiological remodeling, which is generally taken as 1 to 1.5 millimeter of marginal bone loss. But Mission co-workers wanted to give us a little bit more than just this one broad definition. So they actually split it down into 4 different categories. There's success, which basically says that there's no pain, there's no tenderness, there's no mobility, there's less than 2 millimeters of radiographic bone loss since the surgery because of that physiological remodeling, and nothing else is going on. Then they've given us those 2 interesting little categories in the middle, which is satisfactory and compromised survival. And that's basically saying the implant is there, but it is with problem. These include ongoing bone loss, so up to 4 millimeters of radiographic bone loss, or even having sensitivity on function. So basically the patient having issue when they're trying to function with this implant. And that could be even up to more than 4 millimeters of bone loss. So up to half the implant body. That is considered compromised survival. And unfortunately, whenever you look at studies, you tend to find all categories 1, 2, and 3 all lumped in together with each other. So they are considering a survival of implant or a successful implant is having a probing depth of more than 7 millimeters. That's absolutely ginormous. And only at the end stage where you're getting mobility, pain on functioning, and more than half the implant having lost bone, are they then considering it a failure, or obviously if it's no longer in the mouth. And the interesting thing is that in the new classification of periodontal diseases and peri-implant diseases that was published in 2017, they showed that if you have more than 3 millimeters or probing depths of more than 6 millimeters, then you're considered to have peri-implantitis by default. So they're saying that an implant that has significant peri-implantitis can mean there is still compromised survival. So that becomes a little bit interesting. So basically we're talking about if you lump success and survival together, because that's what most papers give you, and then compare it to failure, it's either the implant is there or it's not. And if it's there, we don't know what condition that it is in. And if we have a little look at the frequency of these happenings, there's quite a large number of papers. So one of the papers, Holm, Peterson, and co-workers in 2007, they showed that for implant fixtures, just the fixture, not talking about the prosthetic, after 10 years, the survival is anything between 82 and 94%. If you read that the other way, that means that failure is anything between 6 to 18% at 10 years. Now, when you look at that, that's saying a maximum of 1 in 5 implants would have failed by 10 years. And for those ones that are sitting in that category, we have no idea what state they're in. And when we're looking at the prosthetic, so that's what's sitting on top, when you look at it in comparison to a fixed partial denture, which is basically a bridge or a cantilever, you can see that at 5 years, it's by and large the same. A bridge is the same as an implant crown. And at 10 years, they're again acting very similarly. And I want you to really think about this whole survival and all these compromised circumstances, because if you do apply that to a tooth, you can say a retained root is a surviving tooth because it's got issues, it's got bone loss around it, it's carious, but it's there. And we don't really accept that. Like if you come to me into practice and say, this is a surviving tooth, and you look at it and it's just a retained root, most people will be like, no, it's not. This is failed. And if you have a look at 10-year data, when we're looking at endodontically treated teeth, we are expecting them to have a survival, which is also analogous to success of 90%. And that increases if you're even having specialist endodontists that are working on these teeth. Even periodontally compromised teeth have a better performance than the implant. So there was a group by Greats and co-workers who had a look at patients with aggressive and chronic periodontitis. And they found that after 15 years of SPT or supportive maintenance, 66% of teeth which were considered hopeless still survived. They're still there. When you're looking at even molars with a grade 3 furcation involvement, that is quite severely affected. After 5 years, only 20% of them were lost. So more than 80% of these teeth were still present. And when we're looking at periodontally compromised molars, after 10 years, you still get a 90% cumulative survival rate. So we seem to have very lenient criteria for implants, but we have very strict criteria for teeth. And I think you then have to think about it from another angle. Most of the studies that report you on survival and success, where they are placing these implants, they have already done an exclusion where patients were excluded from the study if they're a smoker or have poor hygiene or systemic diseases or poor quality bone or parafunction. So when you really take a strong, hard look at the numbers, we can see that there's a clear overestimation of the true survival rates of these implants and an overrepresentation of what success could actually mean. And that's what made Setzer and Kim put this statement in the paper. They said, reporting to patients implant success and survival rates more than 95% is erroneous, as many of these data were based on ideal circumstances and the reality of the general population has far lower outcomes. So from that, we can see that failure is quite a common happening. It's not something that never happens. It's not something that is only ever happened once every so often. It's quite a frequent happening. And if we're going to talk about a frequent happening, we better understand how that is classified and why it occurs. So let's talk about the classification of the failures. Typically, there are two types. They're either early or late. Early means that the osseointegration never actually got established. So basically, you put the implant there and it didn't work out. And that could happen because of multiple reasons. So part of it could be operator related. So, if an incorrect drilling protocol was used and there was bone necrosis that happened because of overheating of the bone, or if there's contamination of the surgical field or of the implant by being touched by other things, or if the osteotomy protocol wasn't followed properly and there's poor stability of the implant and it's just spinning around vertically and, horizontally that way, or if the implant was placed in an erroneous location. And by that, I mean that it's impinging on an inferior alveolar nerve or into a maxillary sinus or lost in the tissues or into the incisive canal or something like this. Or it could be related to operator experience, if they haven't done any before and they've had some issues that way. The early failure could also be because of the patient themselves. So it could be a poor patient, compliance or poor medical health. They have uncontrolled diabetes or stress or radiation. If they have poor hygiene, if they don't follow your instructions, if they get hit by a bus, because they had an accident and so the whole jaw gets affixed. If the bone location in their mouth, the location in their mouth has inferior quality bone, like the posterior mandible or the posterior maxilla, or if they're a smoker. There's a lot of reasons why early failure can happen because of the patient themselves, or it could be related to the implant. And this is probably a little bit less common, but things like manufacturing faults and problems with the implant design and things like that. That's the early failures. Now we have a look at the late failures. And these ones are when you've placed the implant in and it had succeeded, and then it starts to break down again. And generally, the main one that gets sort of pulled up about this is the peri-implant disease, which is a biological related failure. Generally, it happens over a period of time. After a couple of years, you start seeing loss of the bone and areas of infection and inflammation in the gums or the tissues around the implant. It can also happen because of mechanical overloading. And this one gets a little bit downplayed because a lot of the times whenever we see an implant that hasn't worked out so well, we look at it and say, oh, what's wrong with the implant, but it mightn't be anything related to the implant. It could be what's actually sitting on the top of it. So if the prosthetic design is poorly and it's resulted in a biological issue, or if there's overloading, and typically after 4 to 6 months you start to see issues. Or it could be, something that's more specific. There's been reports recently in the literature that patients who had implants that had succeeded and were perfectly fine, after a while, if they started taking things like anti-resorptive medications or, bisphosphonates, they start to then see osteonecrosis around the implant, the bones that are supporting the implants. Now, I'm just going to come back to the case that I spoke about, where you can have mechanical failure, the mechanical overloading can drive failure. And this is a case here that I had seen, and it came to me and I was really baffled by it because it looked like the clinician had done everything by the book. So basically, this was a patient which was congenitally missing a canine and had a baby lateral, a primary lateral present in place. The lateral was removed, an implant was placed at the site of the 3, looked perfectly fine. And then basically within 6 months, we can see after it got restored, we can see that there's been total loss of osseointegration around this implant. And basically, then it got referred to me to see if I could remove it, and the patient was interested in going again and having another go. And I was just sitting there thinking, they've done everything by the book, like what's wrong here? And then it dawned on me to check the occlusion, and every time the patient was sliding into excursive movements, they were overloading the bejesus out of that implant. And basically, the unfortunate situation happened that due to the overloading, there was total loss of osseointegration around this implant. So basically, these are the concepts of failure. These are why things can fail and at what time frames they can fail. But what is our intention really? Our intention is that we don't want to just place an implant and get it to function and survive and just sit there and it's fine. What we want is we want to get something that does hit that therapeutic goal, but also to be able to provide something that is functional and aesthetically acceptable to the patient. And that means that we're not just trying to avoid failure. What we're trying to avoid is complications as well. And complications, similar to failures, are classified. So they can be of different types. They can be biological complications, and these are either recoverable, as in you can do something about it straight away and then you can come back from it, or they're unrecoverable, which means that once it's done, you kind of stuck with it and you have to deal with it that way. Recoverable biological complications can be like, immediately after a surgery, if you have like hemorrhage or a bit of swelling or, a bit of a small infection that gets managed with antibiotics or antimicrobials, that's a recoverable sort of type of biological complication. An unrecoverable one is when there is damage to vital structures like inferior alveolar nerves, or if you have a sinus that becomes affected or an adjacent tooth that becomes affected by it, or things like mucositis and peri-implantitis. From a technical standpoint, you can also have recoverable and unrecoverable complications. So recoverable ones is like if you have a restoration on an implant, and so you've got a bit of screw loosening or a bit of screw fracture that you can replace, or the device becomes de-cemented or loses its retention, or if you've got a PFM kind of prosthetic where you lose a bit of the veneering material, these are all recoverable. Other ones are unrecoverable. So things like if the implant is placed in a poor position, that it's actually not restorable, or if the interocclusion, the vertical height does not lend itself to being able to restore that implant. So you end up either having to bury the implant or shave down the opposing to make room. And aesthetic complications is the third component. And again, there could be things that are recoverable, like suboptimal colors of prosthetics. You can just ask the laboratory to make you something else, or it can be unrecoverable or difficult, surgically needs to be managed. So things like having dehiscences in the soft tissues, having recessions happen, having poor papillary heights. And the astounding thing is that when you look at the statistics of complications, cumulatively, you're looking at 48% at 10 to 12 years. So about 17% due to biological and 31% due to technical complications. And the problem is when you have an unrecoverable complication, the implant has to be removed or has to have some surgical, management. When an implant is lost, typically there's a significant amount of bone loss that accompanies it as well, which means that then later on for you to be able to get in and do something else in that space, that becomes quite more challenging and requires more surgical steps, be it like a stage augmentation or first and hard and soft tissue grafting, whatever it may be. And when you actually compare it to like a normal tooth-supported bridge or a cantilever bridge, you'll actually find that an implant crown is more likely to experience complications compared to both of these other ones there. So that's a bit of food for thought. Complications are incredibly high rates. So we have to be able to, as best as we can, try to minimize the occurrences, but we also have to be pretty good at managing them, because if 1 in 2 of your implants in 10 years time is going to have some form of a complication, what you'll find is that you spend a lot more time spent, managing complications and a lot less time actually placing dental implants in people. And we know that the prevalence of biological complications, as in peri-implantitis and peri-implant mucositis, is on the rise. If, in fact, I take out more, well, I shouldn't be saying this, but I do take out a lot of implants, and sometimes that statistic can actually surpass however much I'm actually placing in. And if we have a little look, they did a systematic review and a meta-analysis, Lee and co-workers in 2017, and they found that 1 in 2 patients will have some form of peri-implant mucositis, and 1 in 5 people will have some form of peri-implantitis. And that is regardless of the length of time that implant has been in. So we have to be in a mindset, if we're going to be placing implants, if we're going to be looking after these patients with implants, we have to be in the mindset that failure is a reality and a possibility, and it does happen. And it's not because we're dodgy or we're bad, it's because there could be other factors that can come into it as well, like host-related factors that I've just spoken about. We have to be aware that complications will occur, and we have to be in the mind frame or in a technical way able to manage them when they do come up, or try our best to minimize them in that way. And, sometimes, this is an example of a biological complication. This patient had this implant for 10 odd years. She had never even had it restored. Unfortunately, her husband had lost money, had lost his job, and she didn't have enough money to go back to the clinician and have it restored. She did not know or was not aware that she was meant to have that implant maintained or stay clean or to have any form of servicing. So she just stopped going to the dentist. And unfortunately, when she did go back in, we can see that there was more than 50% of bone loss around this implant. And she said, look, I'm never going to really restore it. I'm never going to really keep it. I just want to have that taken out, and I don't want to go down this pathway again. And when I just took off the healing abutment, you can see the amount of plaque that built up around this. And this is one of the main things that I constantly talk about, and I'll talk about more towards the end of today's presentation. It's really important to constantly try to maintain and look after the implants, as opposed to just placing and thinking that it's going to be okay, because these complications will come up, and you're better off to be seeing that patient on a regular basis and being able to troubleshoot these things at an early stage than in having them creep up on you at the end, where unfortunately there is an unrecoverable complication and the implant requires to be explanted, as is what happened in here. And I also indicated that about the aesthetic complications. This case, I actually didn't see this patient in person. This was sent to me via email from a clinician interstate. And they were just asking me for an opinion. They said, what do you think I could do? I mean, the patient is lost the papilla between the 1-1 and the 2-1. Implants were placed quite some years ago, and it's a young person. He's 30-something years old. So am I able to do something about it? And I said the issue is that there's obviously peri-implantitis happening at least around one of these implants, although I haven't clinically seen the patient. But aesthetic complications are quite common when you've got 2 implants side by side, and it's quite common for you not to see a papilla develop between them. And then sometimes that requires more of a prosthodontic rehabilitation than anything was a clinical periodontal practice, because unfortunately, as brilliant as we are in periodontics, we're not particularly good at growing papillae between implants or between teeth or between anything altogether. If we could, our patients would love us, but unfortunately they don't. So I'm going to go through and show you some of the cases. Again, These cases are cases that I've seen, that I've taken a lesson out of. This is not scrutiny of anybody's work. I'm sure everybody who's done this work intended to do it with all the best intentions, but unfortunately, sometimes things just don't work out. And as I've demonstrated before, the statistic of complication of and of failure is quite high. It's not that it's like once every blue moon, it happens, and it happens quite often. Now, I've grouped these cases based on what I thought were categories that I wanted to really talk about. The first one is patient selection. This was a patient that was referred to me. Now, this patient was 60-something years old. He had had a lot of periodontal disease, and he had lost a lot of teeth due to periodontal disease. And he had seen a clinician who completed for them multiple implants in the maxilla and a removable prosthesis on a bar. But the reason he was actually referred to me was nothing to do with his maxilla. He was more concerned with the mandible. You can see the prosthesis down the bottom, replacing all 4 mandibular incisors, and his concern was that it's moving. So these are some of the clinical pictures. This is the prosthesis here. It is also based on implants. So there's 2 implants underneath this, and you can see that it is a screw retained prosthesis. And basically I took the upper denture off. He said, look, I know there's problems with my upper implants, but I don't want you to touch it. Just leave it alone. I just want you to look after the bottom and see if I can do anything, if I can have more implants, or if the implants can be fixed up in any way, or what can happen. And I said to him, okay, I'm just going to have a look and see what's going on. This is the OPG of that patient. So basically, there were 4 implants that were placed, but unfortunately, after the placement of the 4 implants, one of them underwent a failure. So it was not engaged into the prosthesis, and instead of them having a fixed all-on-4, they ended up having to have a bar and a removable prosthesis, as what we showed before. We can also see that there was quite a bit of periodontal disease. This tooth was removed due to retained roots because it was quite carious. And this is the prosthesis down the bottom that he wanted me to take a look at. And these are some PAs here. I don't know if they're showing up clearly or not, but what you can see is that on one side, the implant has a little bit of loss of bone, but it's not so significant. You could say that this is physiological remodeling. On the other one, we can see that there's basically a V-shaped bone loss around both sides. And this patient, I have to qualify what I'm saying. This patient obviously has very poor home care protocols, poor oral hygiene. They were a smoker, continued to be a smoker. They've had a history of periodontal disease and a history of high dental caries. So in general, the patient wasn't a great selection, but unfortunately, they put a lot of pressure on the clinician and said, I would like to have this treatment to be done, and please do so. And basically, what I could see is this was quite interesting, because you can see, even despite everything, this implant is actually performing quite well, despite the amount of inflammation in the soft tissues that I just showed you before and the amount of calculus buildups. On the other hand, the other side, the reason that it was loose is because the prosthesis was not seated properly. So you can see it's completely dislodged, and there was screw loosening, and the prosthesis had lost retention on this side over here. And so obviously I had to remove that implant and then basically just covered the other one and left it there. But the lessons that I learned from this case was really focus on my patient selection. Make sure that, I'm really checking every single patient. Just because a patient persists and insists on a dental implant, we are in a position to say, look, from my vantage point, from my clinical practice, I don't recommend this treatment option for you. And we do have the capacity to say, no, I can't do this because I don't think it's in your best interests. The other thing as well is that even in patients who have a lot of things going against them, some implants miraculously seem to succeed. It's kind of like if you've ever been in a situation where a patient comes in and you're doing, for example, a root canal on the tooth, and you do everything perfect by the book, and still the tooth is having problems. And then you look over to the other side on the OPG, and there's been this tooth that was treated like 25 years ago, and there's fractured files and things in it. And you say, this is not really like the optimal way of doing the treatment, and yet it's completely asymptomatic, and you start just banging your head up against the wall like, I've done everything by the book and it's still not working out. And here's this, you know, treatment which wasn't really following principles that I would at this stage in my career consider the appropriate way of doing it, or the recommended way of doing it, and yet it's working really well. So aside from the fact that, you know, my lessons to learn from this is choose the patients wisely. Don't be surprised as well that even in some patients who are not ideal candidates for implants, they still have things succeed. The other thing is the importance of prosthetic design and the importance of ongoing maintenance. These implants were done 7 years ago and the patient disappeared. So they never actually went back to the clinician for them to be able to check anything. And obviously over the course of this 7-year period, that bridge started dislodging and having issues in that way. Another case that I wanted to show you is basically a procedural related thing. So a common one that I tend to see is trying to put implants in fairly close proximity. And unfortunately is what that results in is if you violate the distances or the recommended distance of having 3 millimeters between the two fixtures, what can end up happening is that you can have very small bone in between them, and then that can become lost very quickly. And also it becomes very difficult for the patient to cleanse that side. So this patient here could not clean in here. And the reason that the two implants were placed so closely is because you can see that there was the loss of the tooth behind here was because of periodontal disease, and there was insufficient height to place the implant further back. So sometimes, you know, we try to squeeze things in, but it's always a good idea not to try to violate the biological principles and to constantly keep that distance between the implants. This is another case that I got. This one here, again, a procedural related thing where this patient had this bridge done. So you can see it's quite an over contoured bulbous bridge here. And you can see one of the screw access holes is sitting over here. I don't know if you can see my cursor or not, but it's just there on the right-hand side through the middle section. And then if you look at the occlusal, you can see there, this is the other screw access hole over here. So alignment was a bit of a concern in here. So you can see there is one, there's the other. And when I took a PA, I can see again, the same issue has happened where this clinician tried to replace the missing number of teeth. Obviously, there was limitations in terms of where the sinus was sitting. So they tried to put the implants a bit closer together, and obviously that's resulted in a complete failure of the prosthesis and the fixtures underneath. The other interesting finding was that there was a retained tooth root and some gutta perca material in there. So the management for this, unfortunately, was to remove the whole thing. The fixture at the distal aspect came out together with the prosthesis, and then I had to explant the other fixture. And I wanted to show you this case because after I've removed this, I just removed this conservatively. Obviously, I had to open up and clean out the defect that's in there. So when I opened up a 3-sided flap, you can see that there's very large amounts of chronic inflammatory tissues. There was retained root. There's the retained root of the tooth, which I've taken out. And when I curated and cleaned the whole area, you can see that there's a very significant defect in the bone that is present there. And that's the unfortunate things was when implants have issues, and this lady obviously didn't have any maintenance or follow-up after her appointment. And so when issues are not picked up earlier and then they're left to progress, it can result in quite a large amount of loss of bone, which this patient wasn't interested in further implants, but she was interested in a partial denture. And we had to talk about what will happen once, you know, the healing occurs. Is there going to be a complete collapse of the soft tissues? Is that going to complicate her partial denture wearing? And we had to do some grafting just to, as best as we can, build up the ridge profile so that she can have a nice partial denture to wear on top. So from this case, there was a lot of lessons learned. So don't place implants too closely to each other. There was periodontal disease. She didn't have it treated. So that would have been a thing that is always a good idea to treat the periodontal disease. It's not a good, it's recommended to treat the periodontal disease before placing any implants. When planning for implants, a CBCT is always a good idea, because if you try to use an OPG or a two-dimensional PA or something like that, it might not give you all the necessary information that you need. And so what that can result in is basically missing critical pieces of information which would modify or change the surgical protocol. And it is important to remove these items from, retained roots or gutta percha or foreign bodies or foreign objects from the surgical site before you place before you do complete the implant, not just to bypass them, but it does need to be all removed. And it is important to have maintenance and follow-up care. And this is another key man. This one was, again, an issue where the patient was starting to have problems brushing and cleaning around that implant at the 3-7 site. And this case was referred to me by a colleague, and not that they were the one who placed it. It was in somewhere else, completely overseas. And she said, I think it's because of the 8. And I said, look, I completely agree. The 8 is mesioangular impaction. It's not really the ideal abutment or candidate to be sitting there beside an implant. And so it would have been a great idea to manage the perio of this patient, to manage the caries, and to remove these sort of impacted 8 situations before placing an implant in that site, as to avoid, food impaction and ongoing problems in these spaces. Other aesthetic failures that I've seen in my practice. So this was a young lady. She was 30-something years old. She had the misfortune of having trauma when she was young. Both teeth were avulsed when she had a fall, and then they were replanted, had endodontic treatment, apicectomies, all the works. Again, they failed. And then the site was quite compromised. She had to have, the implants placed and grafted, but unfortunately there was issues. And a very similar situation has happened where 2 implants in fairly close, not that they were too close, but having papillae occur between 2 implants can be quite a challenging sort of situation. And on top of that, the tissues, because the site was so compromised because of the injury, had lacked some of the keratinized tissues around them, and they had some dehiscences. And so that site became susceptible to peri-implantitis. Fortunately, she has a very low smile line, or lower smile line around this area, so it's not as obvious. And unfortunately, this patient was lost to follow-up, so I never really got to go through the management procedures with her. But I had basically spoken to her about maybe considering to either just maintain them, but they're not ideal. We can try to do some form of connective tissue grafting around here. But again, it's not going to be a guaranteed situation, because you can actually see the threads of the implant showing. The alternative is to consider removal of the implant and maybe some form of a prosthetic, like a cantilever, sort of off of the implant, like the 1-1 implant. There was a few options we had discussed, and I think she just went and decided to have a think about it. I'm yet to hear back from her. And I'll just show this last case, and then we're just going to wrap up after that. So this case here was one of the cases that sort of got tattooed into my brain. I saw this back when I was in Sydney. It's an unfortunate 56-year-old gentleman who had migrated to Australia. He had this work done overseas. Basically what happened is that he got a mouse trauma, and he ended up having this back in 2010. He had this massive bridge joining his implants and his dentition. Within 5 years, there was peri-implantitis and failure around one of the implants and caries underneath the remaining teeth. So he ended up having these. He went back to the same clinician, had the bridge removed, and then a new set of implants being placed. And unfortunately, within a few years, he ended up having quite a large number of complications. So there was an implant that was displaced into the sinus. There was a fractured implant. There was one with peri-implantitis. There was loss of retention of the prosthesis in one area, peri-implantitis, and a mixture between peri-implantitis and missing graft, because the implant was into the sinus but was not really grafted. There was obviously the issues of dental caries and periodontal disease as well around the place. And that's that over there. And basically the reason he was referred to me was not for anything but to manage this swelling up in quadrant 1 over there, which has come up, and now he was quite sore and he was having nasal issues as well. These are some of the clinical pictures, so we can see very clear issues with hygiene, caries, periodontal disease, and prosthetic design, and the implants themselves are quite affected as well. This is a CT scan showing the implant having been displaced into the sinus. The patient wasn't sure, neither am I, how the implant came to be displaced within the sinus, but it was there. And so when, in the workup of this patient, I had to sit down and explain to him that there was periodontal disease, caries, implantitis, mucositis, fractured implants, failed implants that are displaced into vital areas, and obviously they had a very complex treatment plan, which I did in conjunction with a prosthodontist colleague, where I had to remove the prosthesis. You can see the swelling is quite significant over here. And unfortunately, there wasn't really a way but to surgically retrieve and remove both the fractured implant. And actually, the reason I put this picture here is because typically when you have these implants fractured, you can see that there's a crater type bone loss around it in there. So you can really see what issues with implants can do to the surrounding bone, and how they can then become an issue of, they can sabotage any potential later on for re-intervening in those areas. Not that this patient was a good candidate for that, but in any case, this was basically I had to go via lateral window approach. So that involved basically opening a window into the sinus. That's the sinus membrane. Now, my issue when I did that is I couldn't see where the implant was. So I had to use trans-elimination to be able to identify where exactly the implant is, open into the sinus, retrieve the implant, stitch it all back up to find the other broken implant out, and then close back everything back up. So look, I've just gone through and shown you a whole heap of cases on, whether it's patient selection or procedural issues or follow-up problems. And so if we're going to talk about this topic, we need to talk about how to avoid disaster. And basically, it's doing exactly the same thing, where we would have a proper selection criteria, we would have proper preparation, and then we would be able to maintain those implants. And the temptation generally with patient selection is that if we are trained in dental implants, or a clinician that has done that a lot, that tends to be your knee-jerk response, where you just want to play something that you're very excellent in doing. But if all you have is a hammer, everything looks like a nail. So always resist the temptation to do that. Remember that a patient always comes in asking for a tooth replacement. They never come in asking for a dental implant. Well, some do, but what they want is to replace that missing tooth. And so we do have an ethical consideration where we must first do no harm to this patient. We must have a justification for the treatment that we're doing. Why is it that we're placing that implant in that patient? And the benefit of placing an implant in a patient must outweigh, anything like financial remuneration, the time spent, the patient inconvenience, suffering, going through a surgical procedure, the need for future care. The benefit has to outweigh all those sorts of things, and it has to deliver a superior outcome compared to other things. And so whenever we're doing case selection and treatment planning, it's really critical to take into consideration all the aspects. And these include the patient's medical situation, if they have diabetes, or they are on blood thinning medications, or if they have radiation therapy or a cancer or something like that, how old they are. You don't want to go placing implants in a 15-year-old just because they're congenitally missing a tooth, because there's issues with that. There's a lot of dental considerations, as in their dental health. If periodontally they have a healthy periodontium that is going to support that implant, how their occlusion is like, the number of missing tooth units, all these sorts of things, their dental IQ, their actual understanding of what they're getting. Implants are considered the Rolls Royce of all the treatment options, so don't give that one to a learner. Make sure that the patient who's receiving an implant is in a position where they are fit to have it and able to look after it, so that and they understand that the risks are there for that implant. Despite everything that you do, it can still fail. And even if it doesn't fail, it can run into complications, and they need to be able to pick up that there's these issues happening and report to you, and they need to be vigilant in attending the maintenance appointments. You should also assess feasibility issues like mouth opening, like patients' psychological capacities to sit through a surgical procedure, amongst other things. Their physical abilities, if they have, tremors or problems in physically being able to tolerate going through a procedure like this. Obviously, you need to do all your assessments from an extraoral and intraoral analysis, assess the implant site. There are numerous tools that are out there to assist you with this, and that's a whole different talk. Today, we're talking about failures, complications, case selections, what to do, things that have walked in. But if you are interested in looking at treatment planning, the ITI has a wealth of resources on, if you're placing anterior implants, the aesthetic risk assessment and how you assess your case and pick your case, and considerations to think about. Other cases like that you're doing, be them anterior, posterior, wherever, there is the SAC assessment tools that is available on the ITI website, which guides you in assessing all these aspects that I've spoken about. And you can assess it from both a surgical standpoint, but also if you're just restoring an implant, you're still running a risk of having complications. Remember, we said there's 37 or something % of technical complications that are possible to happen. So you've got to be able to assess your case from a restorative angle as well. And above all, everything needs to be communicated with your patient. Treatment options, the type of surgery they're going to go through, how it's going to be done, when it's going to be done, what to expect, the benefits, the risks, the alternatives, the potential for failure, the potential for complications, and the costs that they will carry for doing that, and the necessity and the need for ongoing maintenance, very critical, and other things as well that you can have a look at. And basically what the overall treatment goal is. What are you trying to achieve with that patient? And then once you do hit that therapeutic target, once you do get that implant in there, once you restore it and it's been successful, and it's not just surviving, it's successful, it's exceeding what you wanted it to do, then the object becomes into keeping that implant healthy. And I generally use the guided biofilm therapy protocol in implant maintenance, which is basically constantly assessing, disclosing, checking for plaque, motivating your patient, being able to maintain that implant surface without damaging it, but effectively cleaning it, keeping it healthy, and then being able to recall that patient. I do have a little video in here which basically shows what a maintenance appointment looks like for a patient with a dental implant. So I'm just going to play that now, where you can see here is the assessment bit going on. You probe the implant, you check it. You check it also by assessing visually if there's any issues. You assess it radiographically for bone loss signs and things like that. You assess the prosthesis that's sitting on top of it to make sure that there's no issues. We know that mucositis is due to plaque, so we need to be very vigilant with plaque control. So I disclose all my patients because I'm sorry, but sometimes patients tell me they floss and they don't. So really important to teach them how to maintain hygiene around natural dentition as well as implants. And then to be able to clean those surfaces, both the prosthesis and the implant. Surfaces all need to be cleaned. So you can see these are the tools that I would generally use. And don't be guarded in really getting in there and cleaning around an implant. You do not want anything sitting around that implant. And the prosthesis is just as critical as the implant fixture itself. And more than just this in your like in your implant maintenance appointment, you need to also assess the risk that this implant is going to run into disease. And Professor Lisa Heights Mayfield, she's a periodontist, specialist periodontist in Perth. She's come up in recent times with this risk assessment tool where you're able to factor in all the information that you gather about your patient during that maintenance or assessment appointment and work out the likelihood or the risk that this implant is going to run into problems and how often you should be recalling that patient. And so basically, pick your cases and try as best as you can to do as much preparation as you can for the implant placement protocol. Once the implant goes in and it succeeds, try to maintain it and keep it under close scrutiny or close control, and be comfortable with the fact that despite everything that you do, there's still a risk that there may be a failure. There's still a risk that may be a complication, but keep calm about it. If you're able to treat a complication or a failure, treat it. If not, there's always people out there that are willing to support you and help you. Not at any stage with any of the cases that I've showed did I ever say anything to a patient saying, oh, this should not have been done this way or anything like that. If anything, I just sat back and I learned from these things, and I looked at it and said, okay, clearly they tried to do this, but that didn't work out. What can I learn from this? What can I do to support that patient? What can I do to support that clinician who's run into a bit of a drama? So take home messages, just to wrap up. Survival does not equate to success. Most of the statistics you see are survival statistics. Failure happens. It can happen early. It can happen late. You can get complications, which are basically as good as a failure, except that the implant is not outside the mouth as yet. Very important to have good case selection, good treatment planning, ongoing maintenance, and support is always there. I'm always on the back end of a phone. If you ever need to talk to me or talk to anybody else, I talk to people who are more senior than myself in periodontics, and I get their opinion. Sometimes when I get a case coming in, I'm like, what should I do to support this patient? Maybe I can also get some more information. And above all, if you take nothing from what I've said tonight, take this one message. Be kind to your patients, to your colleagues, to yourself. It's a really stressful profession that we're in. The best thing that you could do is to be supportive and try to do your absolute best to help a bad situation and try to help the patient turn it around and come out with a better outcome at the end of it. And with that, I'd like to thank you all very much for your attention, and I'll be more than happy to take any questions.
Well, fantastic. Thanks, Marina. I'm pretty sure we all are quite astounded by some of the cases, and hopefully we all had good dinner. There was a little bit blood on the screen. Going through the Q&As, we have quite a few. So if you don't mind, I'm reading out. Andrew is asking, what is your ideal recommendations for your patients to clean implants at home? Andrew is having the airflow and is having also the PI tip, but are plastic coated interdental brushes recommended, as there seems to be some evidence suggesting that superfloss being caught in the screws and could contribute to peri-implantitis?
Yes, so very good question, Andrew. So yes, I do agree with you. I tend to use interdental brushes with my patients more often than using superfloss or floss. Superfloss is really great if you've got like an implant supported bridge, so you've got a pontic underneath and you do need to get in there. But I tend to find that from a dexterity standpoint, my patients tend to report more favorably on interdental brushes. And I do agree with you that if the patient is not dexterous enough or they accidentally get superfloss caught underneath the prosthesis or somewhere in there, then that can become an area which can harbor a lot of bacteria. And then that can result in, mucositis or peri-implantitis or anything of that, these sorts of complications. So I would definitely go down the pathway of interdental brushes. And most of the time, patients tend to find them easier to use than superfloss.
Okay, cool. Same, Andrew. Do you think oral irrigation devices with a higher pressure setting have a place in inhibiting peri-implantitis mucositis?
Are you talking about a water floss?
I'm pretty sure that is what Andrew is asking. Yeah.
Yeah. So I would rather be using an interdental brush which mechanically removes the plaque rather than just a high pressure irrigation. I'm not aware of literature that supports that shows a randomized control trial, and I think there'll be ethical issues with that where they just like allow people to use say like an interdental brush versus like a water flosser, and then see which one ends up getting more mucositis or anything like that. But I'm not aware of any randomized control trials that demonstrate one over the other. But my general go-to is the interdental brushes. On top of that, if the patient has already got a water flosser there and they want to put like a bit of chlorhexidine or a bit of mouthwash in it or something like that, and they want to use that as an additive, obviously no harm done. You know, the more the merrier when it comes to these things.
Thank you very much, Marina. One KLB is asking, in the issue of the papilla, how successful is dermal filler for replacing papilla?
Dermal fillers, there's actually quite a few. I think there was a systematic review and meta-analysis that was done a couple of years back. The authors' names fail me, but what they had found is that it's not really like on a short term, you might be able to see some improvement in the papilla, but on a long-term basis, these gains were not maintained. So as far as I'm aware, replacing or missing papilla is a very, very difficult task. And most of the time, the way that it's managed is prosthetics. So either elongating the contact point and hoping for a little bit of infill in there to try to mask that space and maybe just get a little bit of regrowth. But I'm not sure that a dermal filler would be able on a long-term basis to achieve the necessary outcomes.
Fantastic. Well, by the way, Marina, over 700 attendees, and we get quite a few. They're saying, thank you very much, wonderful, enlightening lecture. Thank you. But still, in between, there are some questions. Do you anesthetize all of your implant patients prior using EMS and PerioFlow? Question.
Not really, no. Unless it's a very severe peri-implantitis and they're quite symptomatic, I don't tend to need to use it. If you're talking about, are you talking about active therapy or maintenance? And maintenance, no, I don't need to anesthetize anybody. And I find that a lot of patients actually report quite favorably because the newer machines, they heat the water up to about 40 degrees. So in general, there's less sensitivity around, which is really good because all my patients have either periodontal disease or peri-implant disease, or, you know, they're just coming in for a maintenance for an implant. But if there is active treatment around peri-implantitis or mucositis, depending on their initial symptoms, I may need to anesthetize them just for their comfort and things like that.
Okay. Thank you. Do you use tap water in your airflow, or is there any antibacterial agent added to the airflow water?
I think if you're looking for more specifications on what should and should not be used from a technical standpoint inside an airflow machine, I'd probably refer you to an EMS airflow specialist, a product specialist, to talk with you about what should go inside, because I don't want to say something and then, you know, it causes any dramas with your airflow machine. So I'd probably say I'd refer you to your product specialist, and they would be able to guide you on what is allowed or not allowed to be used inside your airflow.
Very good answer, Marina. I appreciate it. What does your ideal hygiene protocol pre and post implant placement look like?
Ideal hygiene protocol. Look, I'm a results-based person, so I do plaque disclosure, and a lot of the studies that you would see in the European literature, they talk about having a plaque score below 20 or 25%. So that's what I try to aim with my patients to do. Now, generally, the general way to achieve that would be to have an electric toothbrush. And there's been newer literature that has been published to suggest that electric toothbrushes are superior in achieving that compared to manual toothbrushes, as well as using interdental brushes for interproximal cleaning. So that's what I try to do. I don't try to do anything super fancy, because the reality is whatever I do with that patient, I want it to be maintainable so that they can keep doing it every single time and not have a time where they get like, oh, you know, I've got my implant now, so I'm all done. I don't need to do whatever this crazy lady's saying. So I try to keep it simple, just keeping a low plaque control. And sometimes I even give them plaque disclosure tablets for them to take home and to check their own work and just make sure that they are getting into it. And they understand that, you know, if they've invested that much time, money, energy into getting these prosthesis. They want to make sure it works, and so do I. So it's a partnership where you work with your patient to try to see what works in their own lifestyle as well.
And one for our legal friends under the attendee range, with regards to managing complications. How did it work when one dentist placed and another restored the implant? Who is responsible for what with remediation and also maintenance?
This one, I would say, it depends on the circumstances. Sometimes a patient comes to, like, all the cases, by the way, I should make a disclaimer, all the cases that I've shown today are cases that have come to me from having been placed somewhere away, and then they've come in, they've had issues. Now, some of these cases and some others that I haven't shown, if that provider is Australia-based and was in the vicinity, sometimes that provider is the person who has sent that patient through. So that provider has had, or that clinician has had the opportunity to see the patient, to work out that there's a problem because the patient reported back to them. And obviously when they realize that there's an issue, I don't know what conversation they may have had with the clinician, but they come in to the perio practice knowing that there's a problem, and as a separate entity, I'm here to try to help them out and make good out of a situation that is not ideal. That's one group. And for that one, generally the communication would be between myself, the clinician, and the patient, and these sorts of matters would be rectified in that way. Then there's another group, which are the overseas dentistry people. Now, these ones, I encourage them that if they do frequently go back to that country, to maybe try to touch base with that clinician. A lot of times it's a one-off incident where they had gone, they've had this work happen and then come back. A lot of times these ones don't tend to have any legal sort of standing when it comes to these clinicians. And so they come into the practice knowing that there has been issues, the work that has happened, unfortunately, has had complications, and I'm there again to assist them. The third group is the one where basically the patient has decided not to go back to the initial clinician and have just shortcutted it and came to me. I advise these patients that I would like to let their dentist know, because it's my duty to them, or like my professional courtesy, to let the other clinician know that there's been issues. And as best as we can, we try to de-escalate situations and make things non-inflammatory rather than go down pathways of he did, she did, all of that. So I think the general theme, communication, try to talk with the patient, try to understand what has happened. Make sure that in all instances you are understanding and empathetic to your colleague, and that's why I started the talk with what I said at the very beginning. All clinicians set out to do their best for their patient, because nobody wants to, even if they don't have an ethical, moral compass that they want to do the right thing, they don't want to deal with the hassle. So at least the best that I can do is let that clinician know, and then we can see what we could do to try to help alleviate the situation for the patient. So that's how I tend to manage this. So communicate, talk with whoever, and then try to de-escalate the situation if you can. And the sole purpose is to look after that patient. So the rest tends to work itself out.